Hello and welcome to our first live Tell Me More About session of this evening. And for the next 20 minutes, we'll dive deeper into the topic of placing an implant in a growing individual with Kristin Heimisdottir. And remember, we are still live, so make sure you make the most of this session by submitting any question you might have, and they will end up right here on my desk, and I will relay them to Kristin on your behalf. Now, Kristin Heimisdottir is now joining us live from Iceland. Good afternoon, I should say. Thank you for being with us. Where exactly are you tonight, Kristin?
Good afternoon. I wish I could say I was in Paris, but unfortunately, we have the travel restrictions, and so I'm in Reykjavik, Iceland, which is not a bad place.
Yeah, it looks like you're not exactly in your home, right? You look that you're in a wonderful studio as well. We are very glad you are still able to join us tonight via this live connection. You are an associate professor and the head of orthodontics at the Dental School of the University of Iceland, and also you run your own private practice. Now let's dive into the topic and start with the very basis. Is there a certain age limit for insertion of dental implants?
The basic principle should always be that you should wait as long as possible. This is in the ideal world, but we live in the real world, and our patients, they have been wearing a removable retainer or a provisional for a long time, and even years. So this is sometimes difficult. When we live in the real world, we need to realize when the patient stops growing. Like you see on the slide, you can see the changes that occur when the patient is growing, and we have to realize that we have different areas in the mouth that stop growing, or they're aesthetically sensitive, and we have to make sure that we don't place implants into an area which is still growing. So when we come from the growing patient, we reach the adult level of growth.
Exactly, but how can we see if a person is not growing anymore and has come to this adult level of growth?
There we have some guidelines. We used to measure the height, which is good, but that's not enough. Until recently, we used hand-raised radiographs, which is also a valuable method. But some other approach has been recently more used and has been proven to be just as valuable and accurate. And that is to see the maturation of the third cervical vertebra. But to be more accurate, we should be taking and monitoring profile radiographs. And at a certain interval, like 6 to 12 months. And if we don't see any change of the jaw bones for a certain amount of time, we can be pretty sure that the patient has come to that level.
And so if we have determined that the growth has really stopped, is there then any areas that are more suitable to place implants and less vulnerable than others?
Well, when we come to the adult level of growth, it doesn't mean that we don't have any change. If we go back to the slide before, I once attended a lecture with Professor Melsen. She said, Professor Melsen was the head of orthodontics in Aarhus in Denmark, and she said, the only certain stability we have is post-mortem. So we have to realize the changes that are shown in the slide before, that we have some mesial drift and we also have some vertical changes. But if we come to that slide which shows the growth in the mandible, I would like to change the oral cavity into 4 areas. If we start with the anterior front region in the lower jaw, that is the mandible, we sometimes have congenitally missing central incisors. In rare cases, we have a total anodontia, which means that we don't have any teeth. That's very rare, but in these cases, we should place an implant or 2 for these kids to have a removable prosthesis in order to increase the quality of life. But in the cases of a missing central incisor, we usually have deciduous teeth, and we should keep them for as long as possible. But if we look at the growth of the mandible, you see that like after the age of 8, 9 years old, the growth is mostly in the ramus area. We have a resorption anteriorly on the ramus, but we have an opposition posteriorly. And this is why we get place for the molars, for the second molars, and even for the wisdom teeth by time. So this area is not so sensitive in that sense. And if we place the implants too early in the anterior front region in the lower, the worst thing that can happen is that we have some vertical changes which can be corrected prosthetically.
Exactly. So you're saying basically from the age of 8, 9 years, we might be able to go into the anterior zone at least. Do we then need to give special attention? No?
Sorry,
please correct me.
This is just how the growth is.
Okay.
We should not start at the age of 8 or 9.
All right.
But if we go to the next slide, we see the premolar area. I think you need to play the keynote so you see the radiograph because this has some animation in it. But at least this is just showing the premolar area, which accounts for like half of the congenitally missing teeth in Iceland.
Okay.
And that's probably the same in Europe. And it's good to keep the deciduous teeth for as long as possible, especially if, like in this case, we have a good vertical height of the bone, but on that radiograph, it was obvious that the roots were a bit resorbed. And when the clinical picture there was taken 6 weeks after the deciduous teeth were extracted, you could see that the alveolar ridge was very narrow, especially in the buccolingual. So when the implants were put in, if you show the slide again, you can see that we have a buccal fenestration on both sides. And in order to place the implant, this is the last slide.
Yeah, we'll take it a few back. Yeah.
In order to place the implant properly, you need to have some bone grafting procedures. This is one point you have to bear in mind, like you see there, the fenestration of the implants. And the other thing is that if you have an infraoccluded deciduous tooth in the lower, you might have some elongation of the opposite tooth in the upper. So just bear that in mind, and you just have to find the right balance. The worst thing that can happen in this case, if you put the implant too early and you have some vertical changes afterwards, the worst thing that can happen is that you might have to make a new crown, and it's easy to correct that prosthetically.
Yeah, so you say maybe we could be sometimes too cautious. Do we need to give special attention to the aesthetically sensitive areas?
Well, the next slide I was going to show was to show the growth pattern in the maxilla, so we can skip that one. We go to the aesthetically sensitive areas.
Yes, just guide us through which image you want to see, Kristin.
Yeah, no problem. This is the last area in the mouth, but not the least, because this is the big challenge. And we have some, we have like 15 to 20% of the congenitally missing teeth in this area are the upper lateral incisors. And this can be a challenge. And even though it seems harder for the parents to hear that you have 2 missing lateral incisors, we know that as practitioners, that this is, I wouldn't say easier, but this is less complicated to treat than if you have 1 missing lateral incisor. If you look at the case on the slide, we have 2 missing lateral incisors, and they have been replaced by an implant and a crown. And if you remember the slide number 2, where we had the vertical changes, and we assume that this person has come to an adult level of growth, the difficulties that might show up is that we have some vertical changes, that is elongation of the front teeth, of the natural teeth. So to advise the people, the specialists that are putting in the implants is don't put them too high up. They should be like 3 millimeters from the cemento-enamel junction. But in cases like this, especially in young individuals, you shouldn't be placing them more than 2 millimeters up high. And when we line up the teeth, I'm an orthodontist, so when we line up the teeth, we would like to have like 1 millimeter step between the central incisor and the lateral incisor. And when we have this 1 millimeter, it's considered state of the art because the lateral incisor is a smaller tooth than the central incisor. But in these cases, when you might expect that you have some vertical change like elongation of the central incisor, you can reduce that prosthetically, have that maybe 0.5 millimeter. That's my advice.
Exactly.
In the next slide,
Go
on.
on.
We have a bigger challenge because then we have a situation that we quite often see. We have a missing lateral incisor on the right hand of the patient, and on the left hand, we have a natural tooth, but it's a pack-shaped lateral with a crown.
Just double checking here, Kristin, we're looking at the right slide now, eh? Yeah. We're back on track.
We are looking at the right slide.
Yeah, okay, cool.
Okay. So on the right side, we have, is this the right one?
Well, that's why I was checking, because you were describing and I didn't recognize the implant yet. But tell us about this case, because you're talking about an asymmetrical case, right?
Yeah, if you have the asymmetrical case, that's a big challenge, because then if the natural teeth start moving, and they might do that throughout life, this is the right case.
Exactly.
This is the asymmetrical case.
Yes, this makes more sense.
You have the implant on the right hand side of the patient, that's tooth 1, 2. And then you have the crown on the other side, on tooth 2, 2 with a pack-shaped lateral. And if you think about if these teeth start moving, now I think this is another case, but that doesn't matter. But if you just think about the natural teeth starting moving, these vertical changes that can always occur and will do, it's a bigger challenge. So in these cases, try to wait for as long as possible. And you have a stable situation as much as you can.
Okay, so you say once you are dealing with asymmetrical cases, it starts to become important to wait as long as you can. But in the more symmetric cases, you could see if you can do something, and the worst thing that could happen is that you have vertical changes. But which indicators can we use to predict if we will have these vertical changes or not?
You're asking if we can evaluate if you have a high risk or a low risk for the vertical step. Yeah. That can be difficult, but there is a little tool that I think most of the dentists wouldn't use because they still remember the days in the dental school when they were doing the cephalometry, and most of them didn't like it. But the Ceph, the profile radiograph, can be really helpful because we have really different types of people. If we look at the last slide, we see radiographs of 2 different cases. The profile is showing on the left-hand side on the screen is an anterior rotating mandible. That's what we call a low angle case. Mm-hmm. And this case is much more stable than the one on the right hand with a high angle, because there we have a posterior rotation of the mandible. And that's less stable because we don't have any incisor contact. In the anterior rotating case, we have a very strong masticatory muscles and a more stable situation. So we can use that to help us to decide or to evaluate if we have high or low risk of these vertical changes.
Okay, so it's an important aspect to monitor in our patients whether this could be a suitable case or not. Teeth change over time. Is it important that we maintain contact to the front teeth all the time?
Actually, we have some papers from Birgit Thielander from Sweden. They're over 20 years old, but they're still valuable. and good information. And she was monitoring patient subjects with implants, and she found out that in some cases she had the implants resulting in an infraocclusion, and this was especially in subjects that did not have incisor contact. So we have evidence indicating that we should aim to have incisor contact. This is going to be more stable for our patients, not having those movements.
Exactly. And what do you recommend then if we come across a case where we don't have that? What do we need to do?
I think, of course, you're not treating the patient differently. It's more to help you deciding if this is a high or low risk case. And I think you have to be more aware of that these changes can occur. And then you might do the teeth a bit shorter, no. The crown can be a bit longer.
Yeah.
You can have the step a little less, like I told earlier, and just don't place those implants too deeply if you possibly can.
Exactly. Exactly. Now, let me invite our audience one more time that if you are just joining us, we are live with Kristin Heimisdottir talking about placing implants in a growing individual. And you can send in your questions straight here to my desk. So let me know what you want to know. Now, Kristin, later tonight, in about 50 minutes, I will be talking about someone who's advocating to wait as long as possible. So if you just wait with placing implants, isn't that just more safe?
It's always safe. And the best thing is if you don't put them in, then you don't have any risks.
Exactly.
However, the problem is in the real world.
Yeah.
The problem in the real world is that you have so much pressure. You have these patients that have been really, wearing their provisionals for long and removable retainers. You do have some risk for periodontal problems and caries when you have these provisionals. Basically, you should really wait as long as you can. But I think it's important to accept with the studies that I was quoting, and also the findings from Berends on the second slide, which we showed, that we always have changes. We have changes throughout life. And we can't just wait and wait and wait. But of course, you should never put implants into a growing individual. And then it's important to realize when the patient is not growing anymore. But we do have some other issues regarding growing because we have gender differences, like you probably remember from school. Boys, they take longer time in growing than girls. So we have so many different issues. So I think just putting an age limit like 20 years is simply not correct.
Exactly, and that's why you advocate tonight first, understand where growth is, know how to monitor whether the growth is stopping, and then be very aware of the potential risks. We have a question coming in from Emmanuel, joining us here, live in Paris, he's nearby. He writes, if aging around an implant is so detrimental, could an orthodontic treatment be used to counteract this aging effect? Well, this is something you know a lot about, right?
Well, we use implants a lot in orthodontic treatment as anchorage because they don't move. So it can be, it can make an orthodontic treatment so easy because we're always struggling. If you move two teeth, they both move. But if you have an implant and then you have a tooth, only the tooth moves. So theoretically, you could use that implant. But if you have a vertical step of like 1 millimeter or something, perhaps it's easier just to change the crown.
Exactly. So you would not recommend to use orthodontics to move the implant. Well, let me invite our viewers to stay all the way to about 11 p.m. tonight, because then we'll be talking to Catherine Becker, who actually has some interesting research about what you can do into that. Last question from Alexandra, joining us from Athens. Are facial biotypes important to consider? You already referenced a little bit to the angulation of the mandible. Are there other biotypes that we need to keep in mind? Yes,
this is all connected. The high angle and the low angle. I would really say you should study the face, you should study all the muscles and you see what kind of a type this is. When you have the strong muscles and you have the low ankle cases, the anterior rotating mandible, this is definitely something that's going to be more stable in the front. And then you usually have deep bites, which is maybe not always
Exactly.
nice.
Now, Kristin, time is flying when we're having fun. So to wrap up and to summarize for our viewers, if they remember one thing from this Tell Me More About session, what would you say is the most important take-home message to remember?
Aside for keep the end in mind, which is always the most important thing, I would say that a general rule based only on the patient's age is not the correct method, and that's accepted in the literature that we have, when we stop growing, we have changes. We have to, we cannot use just like 1 year as a reference.
Exactly. Well, yeah, go ahead.
The risk of vertical changes on the adult growth level must be taken into account because we have changes. And the rotation of the mandible is important to understand what kind of a whole system you're dealing with.
All right. Well, thank you for giving this more nuanced approach of looking at placing implants in the growing individuals. Thank you for joining us live from Iceland here this evening in Paris, afternoon in Iceland, and we hope to see you back at one of our future congresses.